thank you to the State Medical Association also for sponsoring these webinars and for being in the epidemic we have with the opioid world right now across the country. So thanks for that. It's an interactive conversation, so for anybody that's on the phone or that's viewing this, I'm going to take some pauses for about 15 seconds just so if you want to interject something, feel free to interject, or if you just have something to say, go ahead and say it, and we'll make this as interactive as we can. I appreciate being able to talk to the group today, and the reason I wanted to do this is because there's a big push out there for medication-assisted treatment, certification, or developed for us as physicians to provide that service to the of our state. I equate it somewhat to getting trained in the MAT. I equate somewhat to treating brittle diabetes. So we all get out there and get a certification for an 8-hour course in treating brittle diabetes. Doesn't help in my practice to all the brittle diabetics out there that might need the help if we can cover their coverage. And it's the same way with MAT. Very valuable service that's out there. But I think, how do we use it? And that's what I want to talk about today, is just how will we use the MT for those patients that are opioid dependent and have pain. So I don't really have any, let me just see if I can get my slide presentation moving. I don't really have any disclaimers. I will say that in 1996, South Dakota passed a law in the legislature so we could have the boards of our healthcare services professions report substance abuse to an outside source and receive entity through that as long as you get treatment and report to those boards. And so over the years, the 4 boards listed there have been on that. And right now, the medical advisor on staff to U.S. Health Management Services, which provides oversight to the boards of nursing, dentistry, and pharmacy. Our board has a different program that they're going through right now. And I also just wanted to note that I am part of the med school also, and I teach a Pillar 3 or a 4th-year med school class. It's 2 weeks long, called Chronic Pain and Drug Dependence. And in that, Ellie Schellinger, my partner on that, she is director of the DeGroote Center at Sanford, and together we spend 10 days, 1 day or even a half day with different colleagues across our community here in the Sioux Falls area. So I appreciate all those physicians that are involved in that. I think John Hanson, Chronic Pain, Jim Wilde, Presidency, Jen Tingley at Falls Community is able to provide MAT treatment to patients, and so they spend time with them. Patty Hughes does something called functional medicine. I know Don Flickema does acupuncture through Vera. Richard Farnham is the director of the Methadone Clinic here in Sioux Falls. We have a chiropractor, Chris Huber, who has students for a day. Tom Botel is a PM&R doctor, chronic back pain. This is palliative care. So we try to give the students just a broad spectrum of what chronic pain and drug dependence looks like, and what kinds of treatment options and care plans we can have for them. So we've been doing it for a year now, and we've had great feedback, both from the faculty and from the students that are participating in it. So I just saw an article yesterday that said we don't have enough curriculum in our med schools for addiction and the opioid epidemic, so that's just proof that the University of South Dakota is trying to do things. Want to review the history and the current state of the opioid epidemic, MAT, medication-assisted treatment programs, how to get into that. Well, different kind of types of chronic pain, drug-dependent patients we have, because they can be in different categories and may influence and determine which treatment plan we want to have. Us to review and know the 3 major health components of the chronic pain drug-dependent patient, and then between drug dependence, opioid use disorder, and addiction, as they are different, and then discern the best practice options for treatment management of those individuals. Of course, talking here about chronic non-cancer pain when we talk about the chronic pain patient. So This is a brochure that was out in the 1990s. I think it was 1995. I found it on the internet. It's a hemp that Purdue OxyContin, as you see, it's a Schedule II drug for oxycodone. And it was a handout that they had. And in the yellow highlighted area, you can see where they talk about this. They say drug addiction means using a drug to get high, relieve pain. You are taking opioid pain medications for medical purposes. The clear and the effects are beneficial, harmful. If you or your family have concerns about addiction, please talk to your doctor or another member of your healthcare team. This does not stand in the way of relief from your pain. So promoting the drug with somewhat downplaying the risks. They did talk on another page of this saying that respiratory depression was the most important side effect to watch out for, and they should talk to their physician if they have concerns about it. Also, I took a picture of this years ago. This is a sample box from '99 that I have in my office. See there, Vicopropin, hydrocodone, which at that time was a Category C drug, now a Category II drug. Those are samples we used to get in our office. We'd sign for them. 2 tablets, 75 hydrocodones, 200 grams of ibuprofen. Just kept it on the shelf, signed for it. In October 2014, it was just from an article in Medscape just yesterday. In 2014, hydrocodone was changed from a Category 3 to Category 2 in the controlled substance. And that, one of the effects that was found that was that post-operatively with 19 common elective surgical procedures regarding cancer, cardiac, general OBG, you can see that, the prescribing for Category 2 drug now, hydrocodone, has increased in this study of 22,000 patients across 19 common elective surgeries. And there was an average of 7 tablets being prescribed post-operatively. So I'm not sure if moving hydrocodone to Schedule II has been effective at lowering the total number of pills that are out there. That is yet maybe to be determined. And from the standpoint of the OBGYN, I'm not going to really get into the obstetric world. One of the best places where MAT is used right now would be buprenorphine. Amidone is in pregnancy. So if you have questions or want to discuss that, we can later. I'm not going to cover it, but as you can see right now, incidence of infants having neonatal abstinence syndrome is increasing considerably. Obviously, then their mothers are also having opioid dependence issues. We have opioid deaths each day, which is just astronomical. It's exceeded taxes now for being causes of death, and now for the first time in many years, the average life expectancy in the United States has dropped this year, as you maybe heard recently, and partly that's attributed, we think, to the epidemic opioid that's taken the lives of many young people in our communities. This is a graph that shows how the country is now starting to limit prescribing, and when it comes to acute pain prescriptions for a first-time opioid, we're seeing the total days somebody can prescribe. And as you can see in Minnesota, it's somewhat to 3 to 4 days in a prescription right now. I focus on Indiana for a moment. In Marion County in Indiana, just an example of a county. They show this graph. This is the number of deaths involved in overdose deaths in states over the years. And as you can see, the synthetic opioids, other than those are listed here. Heroin is there. The one that has to focus on the most are those natural and semi-synthetic opioids, because those are the patients we deal with the most. And if we're talking about medication-assisted treatment for us, that's what we're looking at. It's that greenish olive third down, the natural and semi-synthetic opioids that lead to overdose deaths. Methadone, and you see the synthetic. So the synthetic opioids, other than methadone, would be fentanyl, and then good old meperidine, which is Demerol, which we don't see much around anymore. And not belabor too. I just want to go through the classifications that we have of the opioids. I put parentheses because that is somewhat of a misnomer. The opiates are thought to be the natural drugs of morphine and codeine, so those ones that are natural. And everything is based on morphine for determining the strength of a opioid. The synthetics are actually the ones that are called opioids. That's our hydrocodone, hydromorphone, oxycodone, oxymorphone, buprenorphine, which is the partial agonist that we use, which is in the medication-assisted treatment. And the other one is actually made from morphine, and not a naturally occurring opioid. And then whole synthetic opioids, the ones that are produced from scratch, are methadone and fentanyl. I put tramadol in here also in parentheses, not classified specifically opiate, but a synthetic that does have some mood-altering and pain-relieving conditions. The graph showing the incidence of the fatalities. There's oxycodone, hydrocodone, oxymorphone, and hydromorphone are there. Those are the overdose deaths that contributed to prescription drugs that were prescribed. Fentanyl can be also, but that is most likely being manufactured illegally and gotten off the streets as the heroin. For the most part, is the group, when we talk about the legislatures, when they're talking about we need MAT out there because these people are dying of overdoses, this population of individuals, which we consider to be quote-unquote the drug addicts, should be on MAT. It saves lives. Now, those people are not the ones that are coming in to see us in the clinic. And so I don't want to discredit that, but I want us to focus on the patient population that really is the oxycodone, hydrocodone, oxymorphone, hydromorphone group that we see. And here's statistics in South Dakota right here. You can see overdose deaths in 2016, 20 from prescription opioids, 8 synthetic opioids, that'd be your fentanyl and heroin. Heroin itself is there, so that's 10 fentanyl. There'd be some miscellaneous ones in there. So as I would say this is probably significantly underestimated in the sense that I think there are dozens of people in South Dakota that are age 40 to 70 chronic opioids, probably ME levels in that 50 to 100 range, which are dangerous, but themselves are not fatal. What happens is they have heart disease, they have hypertension, they have sleep apnea, they have obesity. By the way, they have a 6-pack or 12-pack of beer on Friday night or Saturday night, and they don't wake up the next morning. And their death is attributed to their heart disease or their diabetes or hypertension. And we do an autopsy or look to see when actually their cause of death was respiratory depression from the combination of opioid with maybe a benzo and or alcohol. So I'll bet the deaths are double to this, and we're just picking it up. And it is that group that I think I want to focus on. I think the types of opioid patients, one is the naive patient. So the opioid naive patient, by definition, is the person that is not currently getting an opioid prescription. Now, they made a prescription every couple months, that type of thing, but for the most part, they are not having any effects of tolerance or withdrawal to drugs. Those people we are now recommending does not have a prescription for an opioid, but they have an acute painful condition, so they go to an acute care, your ambulatory clinic, in the emergency room. It is recommended prescriptions be limited to less than 100 morphine milligram equivalents in the total prescription. Pain is limited based on a tiering system. So if you have a mild surgery, a low painful condition surgery, you'd maybe get the less than 100 MMEs. This might be for like a toenail excision, carpal tunnel release, or API. When you go to a tier 2 or a tier 3, that might be multiple rib fractures, open thoracotomy for the cardiac surgery. I still recommend maybe less than 300 morphine milligram equivalents in the total prescription. We're seeing that information. There'll be more to come. There'll be more guidelines available to us. And then the chronic pain, which we're going to talk about a little bit. So if you are treating someone with acute pain and you want to know specifically what you should give them, here's just two common drugs that we prescribe for acute pain: hydrocodone and oxycodone. These are the total number of pills that are recommended as the maximum amount for suffering from acute pain right now, right there. Now, again, if you go to the SDSMA website, and when you go take a look in there, it takes you to like news and activities going on. And if you click down on there, it talks about for providers. If you click on providers, it takes you to this page. The page has all kinds of resources for us. And I just happened to copy the algorithm for pain management. This talks about what to do for the person with acute pain. If you want to start them on an opioid, if you do, what do you do? If you don't, what's the algorithm to go by? And so this gives that. This came out in 2016 in March. There was 12 steps that are recommended when prescribing for chronic pain. And this is now going into the chronic pain world. This is the website that you can go to download the PDF. I like this. I still follow this. I think the SDSMA is actually a little bit better one. I'll link to that here in just a minute. But this is very popular. I'm sure you've all seen it. And it just, again, here's a MedScape article from just like 2 weeks ago. And put in this reminder for prescribing opioids for chronic pain. These are those 12 planks right here again that are recommended. And very good to go to use as a resource. Acute pain. Let's go to high-dose chronic use. For me, I call high-dose chronic use for opioids being anything more than 20 milligram equivalents per day. I just remember back before we had these recommendations in 2016, I always just felt comfortable prescribing that 5 milligram hydrocodone, you know, either Vicodin or as a Norco or as a Lortab. If patients took it 4 times a day and didn't seem to abuse it. So back 5 years ago, I actually had patients, not a ton, but a handful of patients that I gave 20 milligram or 120 tablets of 5 milligram hydrocodone with 2 fills, and I had to see them every 3 months. And interestingly enough, the data that's out there when it came to that CT guideline in March of 2016, they said 20 MMEs was the dose where you start to see risk. I just going to have people off of it, but if I didn't think somebody was diverting it, I just don't lose any sleep at night for my patients that are getting 20 MMEs per day or less. I'm abusing it, and I just don't think they have the propensity to become addicted to it and escalate the level of use. Just personal experience. Again, you have to have for provider page on the SDSMA website. Go and push checklist for prescribing opioids for chronic non-cancer pain. I really like this handout, and I'm going to do a case study. I really generally follow this when I do that kind of work with those patients. With that, I want to get to what I call the 3 components that every single patient that has chronic non-cancer pain experiences. What happens is we tend to ignore 1 or 2 of them when the patient comes in. The first thing is they experience pain, the patient who has chronic non-cancer pain. This is, if they've been on an opioid for 3 months or longer, that timeline is debatable, they are dependent to a drug. That's part of it. I may or may not say that to a patient. When I have med students with me, we want to talk about that. I would say not more than 20% of the time is that documented on the patient record that they have a dependence to an opioid if they've been on it for more than 3 months. Consider that failure to diagnose wouldn't be a reason for malpractice, failure to diagnose. So it's just something to keep in mind. And then the component is the mental health component of these individuals. So anytime the patient comes into my office and they're having chronic pain, one of the things that I ask myself is, okay, what is this I really need to deal with today? Of course, when the patient comes in, they know all about their pain. And so defining chronic pain is something that came out of the American Chronic Pain Association Resource Guide. I really, really like this definition. I've used it a lot. It's having pain for more than 3 to 6 months, some as short as 6 weeks, which adversely affects the individual's well-being. And a definition for chronic or persistent pain is pain that continues when it should not. It's pretty ambiguous, but chronic pain is ambiguous. And it comes down to one of 3 types of pain if they're actually experiencing organ, visceral, tissue, flesh, bone pain. Nociceptive pain, which is damage to tissue. Empathic pain, which is damage to peripheral central nerves. There you get that peripheral neuropathy, post-neuralgia, trigeminal neuralgia. Really tough pain to treat. It's real. How do you treat it? What do you treat it with? A lot of research being done out there. And then there's the sensory hypersensitivity, for which fibromyalgia, the pain quite nebulous, falls into. But what you know is that patients that take opioids for chronic pain, over a period of time, do not have less pain months later. I'm biased in this because my work as the HPAP medical advisor for the last 20 years, I see on a regular basis, and so my patient population is somewhat skewed. I see physicians, dentists, nurses, pharmacists, they come into me with addiction, and they're addicted because they were taking opioids because they're having chronic pain. They get drugs, and to a T, every single person that comes in, I say, what are you doing? Do you have pain anymore? They say, well, yes, I have pain. I say, is it worse? And someone will say, no, it's not. I don't think it's any worse. I just live with it now. Some people say, you know what, it's much better now that I'm off my pain meds. Something to be said for hypersensitivity. So when I have my colleagues say that, they say to me, do not let your patients take these long-term, get them off it. They will be no worse. I think they will be better on their drugs. Don't let them convince you they have to be on their opioids. So that's the perspective I come from, and that's the perspective I take to every single one of my patients. And I want you to have the same benefits that I had healthcare professionals that I work with the same thing. Patients like it, sometimes they don't. Into it. Drug dependence, well, this is what I want to just talk about first a moment. Of normal expected tolerance and withdrawal during treatment has been described as being addiction. When they're the only symptoms present, those symptoms that are when you're providing appropriate medical treatment with prescription meds, including opioids, are specifically not counted when you are trying to diagnose a substance use disorder using the DSM-5. Patients that are demonstrating tolerance withdrawal from a drug that I've given them over time, I've escalated their dose, I'm PDMP, I'm the only one prescribing it, they're taking it appropriately for what I'm prescribing it for, do not have a substance use disorder, even though they're going to demonstrate withdrawal and tolerance. It's a clear distinction, I think, that needs to be made, because there are hundreds of patients out there with this classification. We all have our faces come to our mind when we talk about this. We are the ones that have been prescribing it for that, and so we can't say we have a substance use disorder unless we meet other criteria. What is a substance use disorder? Well, that's when the prescription medicines that we prescribe to them are now being used inappropriately. They're taken for something else than what we prescribed it for, or trying to seek the drug. And I like to use the term seek as one of the major things that will line a substance use disorder and addiction from drug dependence. 11 DSM-5 categories, impaired control, social impairment, risky use, tolerance, withdrawal are the 4 major categories, and severity. So now if you want to put a diagnosis in the chart, you should have either drug dependence, use disorder, and we avoid using the term addiction now in the problems because the addiction more is a symptom than we would call it a diagnosis. So what we see happening is people start using it inappropriately. And these are those 11 criteria for the DSM-5. As you can see, top 4, cravings, urges, that has to do with impaired control of the substance. 7, that has to do with the social implications. It's that. Not managing the things we do at work. Risky business, risky use is in 8 and 9. It's just risky. They even know it's going to be causing any problem. Then, of course, 10 and 11 talk about that tolerance and withdrawal. But again, if you're prescribing it and they're taking it the way you're prescribing it, we don't use the classifications of 10, 11 to give them a mild substance use disorder classification. And then there's the term addiction. And again, I have a student with me, and I'll say, now we're going to walk in, we're going to do a consultation on this patient with chronic pain who's drug dependent. I know nothing more than that right now. And 50% of the patients, when they leave the office, they think that I called them a drug addict and use the word addiction at all through the time that I'm with them. It's what the patients hear. Definition of addiction from the National Institute of Drug Association at NIDA. It's a chronic relapsing brain disease characterized by compulsive drug seeking and use, these harmful consequences. I find that seeking component really is the piece I use to differentiate between a substance use disorder and what we call as addiction. I do use along with the seeking because you may have a person that seems to be addicted, and I find out is that they are a dealer, and so doing are diverting. And finally, I have family members come in with a patient who's on an opioid. If I have family members say to me, finally, someone's listening, we're going to get them off their drug. Thank you so much, Dr. Yuthi. And it's low likelihood that there's diversion going on, unless they're incredibly savvy. On the side, if they say, you cannot stop my husband's drug, this is just killing, you cannot do that. Mine may go up because I'm sitting there thinking, are you so interested in this drug for your spouse in continuing the medicine? Either you're enabling it, which is not healthy, or maybe taking the drug, or maybe killing the drug. And that is very useful information. So I would like to bring the family member, especially when they're driving across the state line, or in some instances maybe even driving across 2 state lines to come and get their prescription for the opioid you're prescribing. Keep in mind. High-dose chronic use patient. That's the patient we see in our clinic every day. Those are the ones that we either started patients on medicines, or actually more likely, they're the one you inherited from your partner who's now retired and or has moved and had put the patient on those prescriptions, and now you have them. The thing you want to watch for is, are they seeking? Seeking within the healthcare system, you're going to identify that on the PDMP. And those patients that I would say may be candidates that you want to get to an addiction specialist, and people that you may want to consider MAT if they fail at recovery or even those resources. I like to use it as a first-line therapy for the high-dose chronic use patient because I'm not sure their function MAT has been proven to be okay over the period of time. Jury's out on that yet. Getting outside of healthcare, there's the person that's using the heroin, there's the person that's doing the fentanyl, there's the person where the family member needs a naloxone prescription on hand. This is what gets all the press service, and we talk about we need to get all of our providers to be able to prescribe MAT. I think those that are legislators and don't have any knowledge of what medicine is about, this is what they're talking about. So I think the way we interpret it, and we want to train ourselves and educate ourselves, is different than people are asking. So components, with chronic pain having that drug dependence, 50% of these patients also have a mental health condition underlying that. So when I see a patient, I'll say, now pain, the other flip side of that coin is drug dependence. Well, more than 50% of individuals also have an underlying mental health condition. And over time, the patient says to me, how did you know that, Dr. Yuthi? I'm on Fluoxetine. fluoxetine. I go, well, that's what we see. So what happens, what we know for sure is when these patients come in, 100% of them are dependent on the drug. We know that greater than 50% of them have an underlying mental health condition that needs to be addressed. I can guarantee you, when the patient comes into the clinic, 98% of the time, I'm in here because of my pain. And that's what I make the appointment for. But if I look at that, and I'm sitting there looking at that patient, and I'm thinking, when I diagnose these, what you're thinking about is not nociceptive pain. You're not neuropathic pain. You're something like agony. Your pain is something like misery. Your pain is something like suffering. And I pill for those things. I try to help the patient understand, and I try to myself prioritize what that I'm really treating here. For the most part, I'm treating their drug dependence and health condition. Treating the pain as secondary. They probably had more workups for their pain than you can count on your hands, and they probably had more surgeries than they've needed before too. Hopefully that tide will change. I want to go through a case study, and one of the reasons I want to go through the case study is because I think we all got this letter not too long ago saying you need to get your MMEs down because we're not going to pay for it. Pre-authorization. So this letter, I'm going to circle right there the link that they in that email to the SDSMA, and that takes me to this website in the SDSMA, and then I got second one down in the for providers checklist for prescribing opioids for chronic non-cancer pain. It's really, really a nice one-page handout. It gives you really the guidance you need, and then you can find all kinds of good stuff. The SDSMA did an outstanding job getting that resource for us and can really help us out a lot. So I'm a patient. She came in to see me after her physician retired. She presented to the clinic and she was taking 2 different opioids for her chronic pain. And while she was coming in to the clinic visit, she said to me, "Well, I'm here because of my pain." And it was her back pain, her leg pain, some pains, never-ending, and she had a never-ending abdominal pain. I wonder what that was from, being on our opioids. And of course, they kept her up at night. She can sleep at night if she takes her opioids. She took her back from the left leg pain, was plus 6 out of 10, ranged from 3 to 11, abdominal pain from a 4 to an 8, completely immersed in her pain. And give me a different word for it. She said, "I'm in agony all the time." I said, "Oh, can you think of something else? If you had, this is a chronic pain, are you agony all the time?" Well, not always, but I am always suffering. So I said, well, instead of using the term pain from now on, let's use the term suffering for you. And oh, by the way, Joan, I have a pill for suffering. I actually think that was very funny when I first said that. The thing is, she was cooperative, cautious, anxious. She was stiff when she walked into the clinic, and extremely tender to light touch, not like our fibromyalgia patient. She did real pain. There's no doubt about it. I mean, I would watch her, and she has had some arthritis, no doubt. Her normal pain levels noted there. Her exam really revealed nothing of significant imminent concern. Her abdominal, again, by the way, was benign, and no focal neurologic abnormalities and no radiculopathy when I did straight leg raising. So she didn't have any neuropathy that I really needed to be worried about this time. And again, this is not uncommon. I'd say for the most part, the physical workup, if you see somebody in consultation, has been done. Of course, you want to keep checking it, but most of the time I find I don't need to focus on it. So, like I mentioned, she has lots of pain. We need to talk about function as well as your pain, and to redirect her from that pain to function as an endpoint. She didn't really want to buy too much of that. Past history, diabetes, some things to note here. A review of her PDMP, which was negative, no suspicious prescription activity. So she was not looking within the system, or the system was not a drug seeker. So for that reason, I don't think she was going to be considered a drug addict. Here's her drugs. A lot of drugs. She's undilaudid, and hydrocodone for her drugs. So Norco and hydromorphone were there. Blood pressure meds, diabetes meds, some GM meds, as you can see. SRI, which I thought was good. A couple benzos, which I'm not too excited about. She is in the ER. This is her discharge summary from 2 weeks prior to me meeting her. And this was, note that today's visit with me was considered an ER follow-up. And she came in, she said, this isn't a follow-up, this is about my pain. This was, as you can see, she came in quite obtunded, received Narcan, which woke her up, and then she stayed awake, so we know that it wasn't, her somnolence wasn't from something else. Did work, she had normal blood work, so there was nothing in there that showed she maybe had an alcohol use disorder. She was positive opioids and the benzos. The psychiatric staff did come in and evaluate her, and she was eventually discharged to home with her husband. So I said, you know, you almost died there, and she had nothing. She would have nothing to do with it. She totally denied any of that. So I says, well, what do you need? He goes, well, I need this. And I said, there's more to this than that. And then she started to get kind of tearful and cried a bit. Did put together a differential diagnosis. I did together an assessment, made it. I listed all these things. So her physical pain was real. Those are in 1 and 2. I think her abdominal pain is likely secondary to constipation from her opioids. Used the substance use disorder severe in the sense that she was experiencing multiple symptoms in the DSM-5 criteria. So I did put that in her chart, which she did not like, didn't appreciate. Came back to see me. I pressured with some anxiety and then her other healthcare issues. Here were the areas where I did think the red ones are the areas I thought she did fall into that. I could have taken 10 and 11 off because she's just taking it for from one provider, but it still would put her into the moderate to high dose. Next, I actually looked at the drugs that she is taking that might be causing some problems and might be risky for her. What was causing her to be obtunded? It was the so I'm not going to spend too much time in here. We look at what is risky dose. Anything greater than 20 MMEs is thought to be moving edge. If you get to 50 MMEs per day, you have a double the risk at the 20. And if you get 100 MMEs per day, you have a 9 times greater risk of having an unintended opioid overdose death than if you get it at 20, just by yourself. There's all kinds of calculators. This is when I got to the SMA. And as you can see, she was taking the hydromorphone, and she has taken the hydrocodone. So those two I had to convert when we checked this. We did not, she was on initially a significantly high MMEs per day. You can see 96 plus 40, 40 MMEs of the hydrocodone. So reduced her medications from 4 tabs, 6 a day, down to 3 a day. And I reduced her hydrocodone from 8 tablets a day down to the first that day. So from her having a significantly high MMEs per day down to 88 MMEs per day. Hydrocodone kept that. I'm reducing her from a significantly high risk to high risk. And oh, by the way, she's still in her benzos. I don't want to taper those very slowly. This action we did for her, that was the plan. She came and saw me then 2 weeks later, and guess what? She actually felt better. Her pain was diminishing. She said that she felt like she was waking up. I had dropped her by way more than the 10% that's recommended. Now, again, I'm giving you the case study of the person that did really well for me. I find that the higher MME dose you're at, if you're in that 100 plus, I commonly drop my MMEs by 25%, 40% the first time. I will use clonidine, a central alpha agent, 0.1 to 0.3 up to 3 times a day as adjuvant. I don't like to use benzos for anxiety. talk up the risk that patients are going to have as far as withdrawal, and they usually have a withdrawal as badly as I make it out to be. Do a urine drug test on her at this time to see what we find, and I did get the opioids and the benzos. She at that first visit, of course, did sign a patient contract with me stating what our plan of action was and the seriousness and the danger that she was on. Again, we actually got her down then even more. Went from the 88, we dropped her all the way down to 40. Stopped the hydromorphone, which is 4 times stronger than the morphine and the hydrocodone. And I find she was still taking, at this time, 8 pills a day. And by just taking 8 pills a day, I said, you just take them when you want to. You don't have to take them. Matter of fact, if you want to stop them, you can. Now, you may feel like you're going to die doing that, but giving you the green light, you can do that. And if they cut it down, they come back to the office, I say to them, you know what? You're the only person I know that was ornery enough to stop that and come in and was able to do it. And for people, that just kind of fuels them up a bit. So actually over the course of the next 2 months was able to get off the drugs completely. I do find that final 10% to 20%, from 8 drugs to 6 drugs to 4 pills to 2 pills, was more difficult than getting her from 138 MMEs to 88. I don't know if it's the same thing or not. Any comments on that? Are these patients that you experience situations from?
I'm just chiming in. Phone lines are open. If you have any questions or comments, please go speak.
Thanks, Mark. We only have 15 minutes left. So what I want to talk about here is, would Joan have been appropriate for medication-assisted treatment? She had better off, instead of me when she was at that high dose, to say, you know what, I'm going to send you into some withdrawals. I want you to come into the clinic, and I've got buprenorphine here that's going to take your away for overdose deaths, and we're going to keep you on buprenorphine long term, or methadone. Methadone would be the other option that she had. And again, I'm in Sioux Falls, and so in Sioux Falls we do have a methadone clinic here. Dr. Richard Farnham is the medical director of that. He actually takes our student during our rotation. That is an option that patients can go to. We don't know what the jury is for patients for long-term buprenorphine treatment. I still think it has some cognitive effects on it. The euphoria you get for it is lost after several days, which is a good thing for the person that has addiction. It is a pain reliever, but it is not as strong of a pain reliever as the opioids are. Works much similar. And so it's not certain long-term, I like to use that as opposed to trying to get them off the meds. I think we have an incredible impact on our patients that we don't really sometimes underestimate. I don't believe the patient can get off the drug, and I need to come into that appointment not saying I'm going to get you off the drug. I actually tell them, my goal is not necessarily for you to be off this drug in the next few months. I just know you're dependent drug. I just want you to be comfortable. I want you to get into a safe dosage. We'll get you as far as we have to get you down. I don't say I want to stop, but obviously that is my goal for every one of my patients, is I'd like to see them off their opioids. This is an article that just came out this month. Does the patient on chronic opioid therapy trust their physician? That. Clinics who implement an opioid risk reduction measure, like we were doing there, a tapering program, they trust physicians 82% of the time. And that's for people who are being prescribed 15 MMEs per day. So that's been dropped down. The control is actually done in clinics that have no action program, and this included methadone clinics. And average MMEs for these patients was 120 MMEs. Higher when they said, do you trust your doctor's judgment in managing your opioid pain medicine in that pain clinic? And they said 86%. just a slight reduction for those doctors, for us who are in the clinic, trying to get them off our drugs. They just trust us. I think we maybe don't realize that enough to say, you know, I don't believe you can come off these drugs. I really don't think you're going to. So I can have that attitude. I can help you get off these drugs in a way not scary to them, in a way that's going to be tolerable. That's my goal. I know that MAT is absolutely essential in our medical communities. I don't want to, when I say I'm not sure it's for everyone, I don't want to downplay and say, boy, they're at risk, we need them to have MAT. Survival is increased. When people with addiction, there's increased retention and treatment as opposed to those that go to an abstinence-based program. Criminality is diminished. We see that being employment, if they're on MAT, again, we don't have longitudinal studies on that. And when it comes to the pregnancy world, definitely buprenorphine and methadone are strongly encouraged and recommended. So this is buprenorphine, it's semi-synthetic partial agonist. It's high affinity to the receptor. So if you're in the field and somebody is not breathing, and you had a sublingual buprenorphine, put that under their tongue because it's going to replace the opioids causing them to have respiratory depression. And respiratory depression is low enough in buprenorphine that may actually save their life. Now, that's off-label use of buprenorphine. But I'm just trying to let you know that buprenorphine is very strong to the mu receptor. Now, when you do that, you're going to throw them into serious withdrawal. But as you know, no one dies from an opioid withdrawal. You'll think you want to die from an opioid withdrawal, but you won't. You can die from a benzodiazepine withdrawal, but generally speaking, from a pure benzodiazepine overdose, that's not fatal. Little caveat. As you know, Suboxone has the buprenorphine plus the antagonist naloxone, and buprenorphine Subutex is the buprenorphine is alone. In pregnancy, it is Subutex which is used. For patients that are prescribed this medication, insurance will usually cover Suboxone if they cover it for addiction. Insurance will not cover Subutex addiction. I know this because I had one patient that did not tolerate the naloxone in Suboxone and recovering from addiction. And so with that person on Subutex, they did much better. Butrans patch, you maybe prescribe that. I did get a consultation one time saying, Dr. Yuthi, I need to get a consult because you have the application for your DA to prescribe this buprenorphine for my patient with terrible rheumatoid arthritis. This had a 20 microgram per hour Butrans patch on, and after we went through and did it, this patient did not have to need it. This patient was not taking it for drug addiction. This patient was taking it solely for the pain they had. So I referred them back to their physician and said, keep taking it. It's working. It's getting the relief he needs. The patient's happy. There's also an article that came out that I looked at recently. So I'm looking for, can we keep people on MAT for long periods of time? You know, we're so quick to jump on this bandwagon to get people on it. We're sure what people are going to be like 1 year, 2 years from now. And so really I'm a bit cautious with that. Actually, an article that came out just this last month, substance abuse treatment, and they compared different studies, and some of the studies showed that there was actually positive effects on MAT regarding functional outcomes, and the outcomes they looked at were cognitive function, physical fatigue, occupational ability to return to work, social behavior as far as criminal and illegal activity, and neurological as far as like balance and dexterity. Half of the studies showed some improvement. Half of the studies showed that people did worse. So what their conclusion was is the quality of evidence was rated low or very low. And some this prevents strong conclusions about the effects of MAT. functional outcomes. So people are like, what do you do then, Dr. Youthy, for those individuals that are healthcare professionals in recovery? Do you let them work as a physician, as a pharmacist, a nurse, as a dentist, also in the field? At this point in time, South Dakota does not have anyone in any of the recovery programs that we have that can work and be on that medicine at this time. The 50 states, 48 states have an HPAP program for physicians. I know 2 states that are right now watching several clinics very closely on buprenorphine out in the practice. I'll just say they're not in neurosurgery, maybe lower risk, because we do know that buprenorphine as a partial agonist has mood-altering components to it. Question, where does the MAT fit this? Use it. A handful of patients that are on it. I've been doing this, I think, since 2005 is when the buprenorphine designation came out. I tried to find out when I got it. I think it was around 2005. So I've been doing this for 30 years and fewer than 20 people on it. But patient population and those patients that I have on it, I do think if they were not on it, they in the throes of addiction would likely not be alive today. One individual is on buprenorphine. It's the 2 milligram sublingual tablet. It's a half a tablet twice a day. And if he doesn't take his buprenorphine, he's into incredible withdrawal at that very, very low dosage. It just shows that people are wired to that need that. He's a very successful businessman in his community, and he thrives on 1 milligram twice a day. So he's a champion for me, and he's proof that we do need the MAT. The question again is, to what extent? Put out by the South Dakota State Medical Association, along with our Department of Health. Really good kind of a conclusion. Talks about this is not just a physician issue. We want our pharmacists, we want as prescribers, we want the things that we can do to try to help relieve this problem with the opioid use disorders. Enforcement, naloxone, I mean, who should have access to it, should be trained in it, law enforcement there, and then finally our substance use prevention and treatment agencies. We have enough addiction treatment facilities out there, and again, we're in the trenches. We're the ones that are going to have to deal with this. We're not going to have those resources. What do we do when we don't have them? Thank you for your time. Again, I want to thank the SDSMA for sponsoring this, and also for having in their website just a plethora of really very good resources for us that we can utilize at a decrease the opioid epidemic and improve the health of our South Dakota citizens.
Dr. I did want to just remind those that are listening in that the phone lines are open. Any questions for Dr. Youthy? Dr. Youthy, if I may, listening you present one of the questions I have is, how does a person make that decision? At what point do you decide MA is your route to go? Do you try to taper them down first and then look at it, or is it something you do and then try to taper? How do you kind of set up a plan, or do you individualize that for each person?
If I have a patient that has been through treatment, has failed addiction treatment several times, they've had a near-death overdose, and I'm afraid that I may not see them again, I will make the move to go to buprenorphine with them at that point in time and try to get the contract going and hope that they have good follow-up with that. Buprenorphine isn't abusable. It can be abused. Now, it's much, much more difficult to abuse the Suboxone because of the naloxone and the Subutex. It can be an abused drug, so we have to always keep that in mind. But just what the risk is for that individual to die from an unintended opioid overdose death see if it's going to be illicit drugs out on the street. If I think they're high risk for that, I would do everything I could to get them into an IOP or an alcohol treatment facility first. That is always my first goal, is to get a team together, a multidisciplinary team, addiction services, mental health, me, and a pain control team if they have pain, and work together. If it's a pure individual who has no pain and have addiction, the person that should be on MAT.
Any other questions for Dr. Youthie?
Regarding that, Mark, and that is, we appreciate our clinics who are really reaching out and providing the MAT. I know the residency program is doing that. I know that the community clinic is doing that. Community health clinic is doing that with Dr. Will and Dr. Tingley. Dr. Wilde and Dr. Tingley, I really appreciate that because that's such a need. But what I find the dilemma is when you have, full clinics, you're trying to keep your head above water as it is with all the pressures we have in medicine. And the willingness and the interest to take on a patient population like that is just not very popular. So it's very difficult to bringing in these patients because, number one, they don't come into the clinic. They're EDs. And secondly is there's work that goes around to that. So I get it. So if people have an interest in doing this work, please talk to Mark, talk to other people in the state, and we can sure try to start putting together a program to provide that service.
Thank you. If you don't mind, I wouldn't mind asking one more question, and that is, we're starting to see, just like many other states, as opioid prescribing comes down, we see an increase in heroin and methamphetamine. And one question I had is the treatment plan different based on what their addiction is to? So like heroin and methamphetamine, with my limited knowledge, are very different drugs and impact the body. So do you have to take that into consideration when trying to work with somebody as well?
Yes, Mark, we do. They are different. Addiction is addiction, so it's one of the reasons we do a urine drug test. If I see methamphetamine in a person's urine drug screen and it's not supposed to be there, the benzodiazepine to be where, first of all, your trust factor has now been breached with the patient, and that's a very, very important thing. The second thing is they now have much greater risk for an unintended death from what I be. You do treat different addictions differently. There is some cross-addiction with one substance to another, but it's not direct correlation. So some people have significant alcohol use disorders where they just cannot use alcohol. And they've had no problems with opioids when it comes to being treated for surgeries, things like that. Vice versa, we see people that have had drug dependence issues and have had no problem with being a social drinker in their world. So each person is treated a little bit differently. Addiction withdrawal and rehabs are different, but the treatment institutes, of course, they do treat everyone that has addictions with some common themes. One of the common themes.
So one last call. Any questions for Dr. Youthie before we wrap things up today? Dr. Youthie, I see you did put your phone number up there and your email address, so I'm assuming you're okay with people reaching out to you that may have questions.
Fine.
Thank you. So, in closing, we certainly want to thank Dr. Youthie for sharing his knowledge with us today. I want to thank all of you for participating. This is the last program in our series. However, all sessions have been recorded and have been placed on the SDSMA website. And Dr. Youthie made reference to there are a number of tools and resources out there at the SDSMA website as well, and we encourage you to take a look at those. With that, I want to thank you all for joining us, and I wish you a good evening.
Thanks.